Good afternoon. Thank you to everyone for joining our cancer support community utilization management roundtable on step therapy. I am Deneen Ciccone, Vice President of Policy and Advocacy. We are about to begin, and the next voice you will hear will be from our CEO, Sally Warner, to offer some welcome remarks.
Hi, everyone. Welcome and good afternoon. We are excited to have you today at our Utilization Management Roundtable on STEP therapy. As Deneen said, I'm Sally Warner, the CEO of the Cancer Support Community, also known as CSC. We are a proud leader in patient advocacy and ensuring that the voices of patients, caregivers, and survivors play a central role in policymaking and implementation. Today's roundtable is part of CSC's Forum on Utilization Management. We are now in our 6th year, which was created to foster thoughtful discussions that engage a broad range of healthcare stakeholders and keep the focus on patients and the cancer community that we serve. Ask tough questions and nuanced questions about when various approaches are acceptable and when they have the potential to harm patient health outcomes, as well as identify new ideas and promising practices that optimize evidence-based healthcare. We're honored to facilitate these discussions and appreciate stakeholders like you for participating and collaborating with us in this challenging but important work. No matter where your knowledge of STEP therapy lies, we are grateful for your participation today for what we expect to be a very educational and insightful conversation. We'll focus on 3 main areas: the impact of STEP therapy on patients and providers, CSC's STEP therapy research, and a discussion on the current policy landscape of STEP therapy, and finally, possible solutions to improve patient access to care. Lastly, I would like to reiterate our appreciation for Mark and Novartis for making today's roundtable and our continued work in the space possible. With that, I'm excited to listen in with you to this conversation today, and I'll now turn it over to Deneen, who will moderate today's conversation.
Thank you, Sally, for introducing our event today. As I mentioned at the outset, I'm Deneen Ciccone, Vice President of Policy and Advocacy at Cancer Support Community, and I'll be moderating today's discussion. Thank you for joining us for our webinar on STEP therapy. Utilization management strategies, such as STEP therapy, are common policies which, when implemented appropriately in the healthcare system, can enhance the patient experience and improve quality of care. However, what we have learned is that they can also negatively impact patient access to care and contribute to provider burden. Cancer Support Community is committed to fostering conversations that inform and engage all stakeholders in the creation and implementation of utilization management strategies that include the patient perspective and incentivize cost efficiency through improved patient care and outcomes. We are all here today because we believe that we have a role to play in making high-quality healthcare accessible to everyone. And to provide some background on today's topic, STEP therapy, which is also known as Fail First protocol, it is a practice whereby a payer denies coverage of a physician-prescribed medication until the patient tries one or more alternative treatments. What we know is that it often ignores an individual's unique circumstance and medical history, which can lead to potentially life-threatening disease progression. We also know that it may also require patients to take medications that previously did not work for them or that can cause serious side effects. Currently, there are about 36 states that have passed STEP therapy protections. However, they are primarily for what we call fully insured plans, meaning that self-insured employer plans are exempt from those state laws. And that is why it is so important that Congress passes federal legislation to protect patients. And one such piece of legislation that we'd like to discuss is through our membership of the Safe Step Ad Hoc Coalition. We support passage of the Safe Step Act, which ensures that group health plans offer a reasonable exceptions process for an individual to be able to seek an exception for STEP therapy practices before they experience physical harm. It also requires group health plans to respond to the exception requests within 72 hours for regular cases, and within 24 hours for severe cases, or more urgent cases, we could say. Support for the Safe Step Act was actually one of Cancer Support Community's legislative asks in our advocacy day last month. And so we will continue to advocate for passage of this critically important legislation that we believe will reduce administrative costs and burdens to providers and practices and ensure that cancer patients have access to timely treatment at the right time. Today, I'm excited to share that we are joined by an esteemed panel of experts on utilization management and step therapy. Dr. Daniel Geynisman, Dr. Erica Fortune, and Mr. Charles Husser. Thank you to our speakers for joining us today. And so what I'd like to do before we kick off this discussion is to kind of share some event reminders or just some action items to keep in mind. So a friendly reminder for our live audience that before we begin our program, we're going to have you in listen only mode. But throughout the discussion, please feel free to use the chat box to submit questions for our speakers. Or if you prefer, you can wait until the end of the Q&A. You can wait until the end, to the Q&A section and then ask your question. So it's up to you. You can enter the question during the discussion, or you can wait and ask your question at the end. We're excited to begin our discussion and look forward to a robust conversation. So with that, let's get started. To kick off our program today, we have invited Dr. Daniel Geynisman to start the conversation by discussing the impact of step therapy on patients and providers. Dr. Geynisman is an associate professor in the Department of Hematology and Oncology at Fox Chase Cancer Center and the division chief of genitourinary medical oncology, as well as the vice chair for quality improvement. He is also the editor-in-chief of the Journal of the National Comprehensive Cancer Network. Additionally, he is a co-author of our step therapy manuscript, which we will discuss later in the agenda. Dr. Geynisman, thank you for being here with us, and I'll turn it over to you.
Great. Thanks so much. And thanks to the cancer support community for hosting this and sort of having this important conversation. I think my role is to sort of put a clinical perspective on this and talk about why step therapy and this topic are important to clinicians and patients. I'm a genitourinary oncologist, so I treat patients with prostate cancer, kidney cancer, testicular cancer, and bladder cancer. And I use both certainly plenty of intravenous therapy, but also a lot of oral therapy and a lot of supportive medications. And, as you heard, really fundamentally, step therapy is about payers, at least to me, mandating us to use certain drugs in a certain sequence and sort of proving that certain drugs do not work before we use others. And really, to me, this is kind of second guessing the clinician. It's second guessing the patient-provider relationship, and it's second guessing what we think are the best therapies. And I think this is probably true in medicine in general, but in oncology in particular, the field is rapidly evolving. What is the best therapy today is very different than what the best therapy will be even a month from now, certainly 6 months or 12 months from now. And there's a tremendous amount of nuance in how you think about a patient, how you think about a particular clinical scenario that will dictate what you recommend. And so simply following an algorithm of what a payer thinks is the right first step to use is really oftentimes incorrect. And so that to me is fundamentally the problem, because we know that using the best therapy first, in particularly in oncology, is critical to have the best outcomes. That has been proven time and time again in clinical trials. you got to put your best foot forward. That's what we want to do. That's what our patients want. And so again, taking that decision out of the, I think, patient provider diet relationship is just wrong. And I think stands the risk of leading to really bad outcomes. So that's sort of my one overarching issue with step therapy. Number two, from my perspective, I think there's actually very little evidence that it saves money, because even if you're using cheaper drugs at first, if those drugs lead to bad outcomes, adverse outcomes, if they prevent somebody from working more, if they lead to more hospitalizations or ER visits, that is actually going to very quickly add up to more cost to the healthcare system and to all of us. And I have not seen any really clear and definitive evidence that it actually saves us all money at the end of the day. And actually, this is part of the work that we did, looking at 5 different oral drugs, showing that really there's seems to be very little cost saving in the majority of cases, with some rare exceptions where drugs are denied for many months, where there you can show some cost savings. But of course, there the flip side is you're not getting the drugs that you want for many months. So you're again denying potentially the best care for patients. I think also fundamentally it's somewhat unethical. It's somewhat unethical to ask patients to receive substandard care, even if it's not oncologic. Let's say it's antiemetics. Let's say it's drugs to help boost your white blood cell count. Let's say it's drugs for neuropathy or for bone health. To mandate a certain drug be used when we know that a different one is better, or that may be better for that particular patient sitting in front of us, is to me really, again, unethical. And I think from my reading of the literature and speaking with others, this is the case not just in oncology, of course. This is a case in, for example, gastroenterology with inflammatory bowel disease, where there are many medications that are expensive, but that are sort of prescribed by the payers to be used in a certain order. In things like arthritis, where you use a lot of biologic therapies. So oncology is not just obviously one area. In mental health, where again, actually studies have shown that trying to do step therapy and using cheaper drugs does not lead to cost savings. In fact, it leads to more costly health trajectories for the patient as a whole over many months. So I think we need to be advocates for our patients. I think that's our number one job and responsibility. I think that means giving the best therapy always. And that is a very complicated question that really only the treatment team knows. And to have to fight for those right medications, as you already heard, actually not only leads to a tremendous amount of burden to the whole team, it actually leads to burnout for physicians, for nurses, for administrators. And that does not lead to good patient care, because now you've got a team that's supposed to be taking care of you that is actually burnt out from that. So when you look at it all, unethical, not putting your best foot forward for the patients, leading to burnout, and really having very little evidence that it actually saves money, to me, it just doesn't make much sense. And I guess that's my bottom line. Thank you.
Thank you so much, Dr. Geynisman, for your perspective. You said a few things that, stood out to me. One, you talked about second guessing. You talked about, patients needing to be kind of like understanding what the process is so that we can help them advocate. And I was just curious, in your experience, how do patients and their loved ones, how do they react or respond when they hear, after this discussion we had, and I trusted your medical judgment, we came to this decision, and I'm being told now through my payer, you have to go through this process. How, as a physician, do you respond to that, number one? And number two, I imagine and when you talk about, provider administrative burnout, you probably have a team in place, right? That you can refer them to help them through that. So just quickly, I was just wondering, what does that look like for the patient from your perspective?
Yeah, I mean, it's a good question. I mean, first of all, it's extremely frustrating. You can imagine if you've made a decision with your team and you understand why that decision has been made, and now we have to come back, or your payer comes back to you and you get some letter that says you're denied for this therapy. It's extremely frustrating. It's upsetting. You are in a vulnerable position at that moment, perhaps one of the most vulnerable positions you've ever been with a new diagnosis, now being told that you cannot get the therapy that we just discussed made sense. So it just adds an extra layer to the psychological burden for patients, not even to speak about the sort of physical burden that they may entail from this by not receiving the appropriate therapy. We try to have resources, financial counselors, folks to help people get their oral medications. And certainly I work at a place, and I'm lucky that has an amazing team in place specifically for this, to be able to navigate all the roadblocks. But a lot of places do not have that. We happen to work at a comprehensive cancer center, so we have some of the resources that other practices may not. And it becomes very difficult. And from a patient's perspective, it's frankly sometimes impossible to navigate this. I mean, we've all had this experience. The letters you're getting, the kind of the roadblocks that are put up are very difficult to understand how to get through. It's just very complicated, very frustrating. And patients have to spend valuable time, sometimes financial resources, to be able to get through all of this. I've had certainly patients say, well, I'm going to pay out of pocket for drugs from another country. I've had patients who try to get drugs that other patients have donated. We've had patients go for quite a long time without their drug as we're trying to work through this. Even in our sort of center, where we're pretty darn good at this and have a whole team, still sometimes there are delays that are significant. So frankly, it just breeds mistrust, right? So you're from the beginning, there is a level of mistrust with the healthcare system, by the patient, by their family. And as a physician, as a nurse practitioner, as a physician assistant, as a nurse, anybody, you're trying to kind of be the middle person. You're trying to navigate both sides, and it puts you in an uncomfortable position. And it just doesn't help us start off on the right foot at all. So it's frankly, for everybody on my side, it's very frustrating. It's just extremely frustrating. Like I said, it really does kind of lead to burnout.
Thank you. Thank you for sharing that real world perspective and experience. And that's what we hear at Cancer Support Community. And I'm sure other patient advocates that are joining us, they also hear that experience as well. But hearing again from a physician that does this day in and day out and really wants to help people, thank you for continuing to keep this at the forefront of these conversations. So with that, I would like to turn it over next to Dr. Erica Fortune. She is our very own Vice President of Research at Cancer Support Community. Dr. Fortune currently oversees CSC's multidisciplinary research team and conducting qualitative and quantitative studies, including our longstanding Cancer Experience Registry. Dr. Fortune is here to discuss the data and implications of CSC's step therapy research and what we can do to support patients. So Dr. Geynisman kind of alluded to this during his remarks, and now Dr. Fortune's going to go into them in a little bit more detail. So Dr. Fortune, thank you very much for joining us today, and I will turn it over to you.
Thank you so much, and I'm very excited to be here. And as Deneen already shared, I'm going to be expanding a little bit on what Dr. Geynisman has already shared with you about our step therapy work at CSC. Next slide, please. For those of you who are not intimately familiar with our CSC research department, I just want to give you a quick glance into what we do. As Deneen already mentioned, we are a multidisciplinary team of PhD level and master's level researchers with various backgrounds and methodologies. So we're able to bring together a really collaborative and unique perspective on the cancer experience. Next slide, please. And again, before we get into the details of the specific step therapy research that we'll be talking about today, I just want to also expand on what our capabilities are as a research team and mention that we do all various types of methodologies, including qualitative and quantitative research, including our cancer experience registry, as Deneen has already mentioned. But what we love to do as a research team is support our other departments, including our policy and our policy initiatives. So that's why I am so pleased to be here with you today to really represent our CSC team and to share some of that work. And I'm also hoping at some point today, I'll be able to share my personal lived experience with step therapy. It is not in oncology, but it is in arthritis. And I have been deeply impacted by step therapy and the fail first method. So hopefully I'll be able to speak to that a little bit more later. Next slide. Great. So I'm giving you the highlights here. So as always, this research was in-depth and robust, but I want to give you just a really quick peek into what was done with this research initiative and what those main findings were as it relates to step therapy. So first of all, the main research questions of interest. In the US, are insurance prior authorization and step therapy practices for oral cancer drugs resulting in a delay in access for patients, right? And if we are seeing a delay in access, what is that delay in access? How long is that delay in access? And also, is there a reduction in the overall healthcare cost when we're implementing those prior authorization and step therapy practices? That's often at the root of the argument for why they need to exist, is that it is going to reduce cost overall. So are there cost savings there? And if so, what do those cost savings look like? So a little bit more about that research process. This involved analyzing real world claims data over a 4-year time period from 2018 to 2022 and included more than 44,000 patients who had been diagnosed with cancer and were on at least one of these 5 specific oral cancer medications. Each patient had a unique observation period starting with the first cancer drug claim submitted plus a unique index date. So that date of the first claim for the cancer drug. And then delays in access were described as the number of days between first rejection of, if any, and the index date. Next slide, please. So overall, let's first start with what those delays actually looked like and were there drug rejections even happening in these 44,000 patients. So the majority of patients experienced no drug claim rejections, right? So that's great news to see in this data. Of those who did experience claim rejections, almost 70% or 30% of the total overall 44,000 experienced a pretty short delay. So 1 to 5 days overall. 5% of those who experienced delays, or roughly 2% of that overall 44,000, experienced 4+ months of delay, which is absolutely not what we want to be seeing in the situation as a significant delay in care for patients. As that relates to the cost savings, for 2 of those drugs, there were no significant differences between those individuals who experienced delays compared to those who experienced varying degrees of delays. But there were 3 drugs where savings were only observed for those who had those substantial delay periods, so those 4+ months of delay compared to no delay. But the important piece of this finding as well is that these savings were highly variable and average annual savings were unsubstantial in comparison to the 30-day cost of those actual medications, right? So what does that mean for us? Next slide, please. What we're seeing here is that the good finding, right? Most patients did not have delays. That's great. And if they did have delays, it was short. But while that's good news, this means that if there are delays and there are rejections that are requiring people to do additional types of paperwork and approvals, this is unnecessary and additional burden on healthcare staff and institutions. And then we'll get into what that means for the patients in the following slide. But I also want to highlight, unlike the others, the 2% of patients who had those substantial delays in care had overall healthcare costs that were significantly lower for 3 of those 5 oral cancer medications that were previously listed. So in some ways, you could argue this does provide some credence to the idea of there being some cost savings in step therapy, but, right, the caveats, and there's multiple here. there's high variability in that cost saving, right? And what we see is that it is likely unsubstantial when you look at the actual cost for those medications in the 30-day time periods. So is that high variability and the small cost savings actually worth it overall? So next slide, please. I would like to argue that what this means, right? The impact, the overall implication, not only for cancer patients, but for patients experience any type of delay or fail first method, is that other research shows us there's significant impact on patients when we are delaying care, when they're going through this fail first process. You're going to see likely a decrease in their quality of life overall. You're going to see an increase in anxiety for patients. This could potentially negatively impact that patient-provider relationship, right? So this was previously discussed about that impact on communication. Are we trusting our providers to give us the best care? If so, what is this denial from the payer doing to that relationship and the trust that we have in our doctors and our healthcare system? But also, when you couple that with the fact that this can lead to increase in healthcare resources. So if you have people that are put on medications that are not necessarily the right medications for them and could also lead to further complications, you're likely to deal with disease progression, lower adherence to treatments, and increased complications that could result also in increased healthcare use, right? So ER visits or additional types of tests or doctor's visits over time. And again, this all comes at a cost. This comes at a cost to the system and to everyone involved. So I think the real take-home message here for everyone on this call is that we need to continue to explore how things like step therapy are impacting patients and caregivers in the entire system, but also think about how we continue to provide the best support to our patients, to our caregivers, because this is becoming an increasing part of navigating the cancer experience. Thank you.
Thank you. Thank you, Dr. Fortune. So you mentioned, you have at the outset that you have a personal experience as well with step therapy, with arthritis. And but I'd like to, ask you to share, your lived experiences with that as well. But I think the data that you just shared really does. It's just, one other really important piece to the conversation as it relates to step therapy and why cancer support communities endorses the Safe Step Act is that we know overwhelmingly, based on our data, this is not, implementing step therapy is not a cost saver to the payer or to the system writ large, but what it does, it delays access, it increases provider burden, and it increases anxiety and other types of effects on the patient. And we know patients that are impacted by cancer and those with other chronic conditions as well, the last thing they need is to have this additional quote unquote worry, right? And that's why we're here advocating and hoping to see the Safe Step Act be passed, this year by Congress. But before we turn over to Charles, would love to hear your perspective, your personal perspective and experience with step therapy, and how was that for you? And how were you able to navigate that?
Yeah, and I appreciate the time and the space to bring that into the conversation, even though it is outside the oncology world. Again, it's in rheumatoid arthritis, and it does really impact the navigation of my care experience as a patient. And that's part of what struck me the most, honestly. So to backtrack a little and give you a little bit of context without getting too far into the weeds, I was diagnosed roughly 2 years ago with rheumatoid arthritis. I've been dealing with the idea of fail first for more than a year. I can't even count now the number of drugs I've been put on, but none of them have been what my healthcare provider really wanted me to start with. I had to go through the fail first, which meant that I was taking drugs that actually had significant impact on my physical well-being. I had side effects that were significant that resulted in numerous additional healthcare visits I would not have had otherwise. I was having blood work almost every week to track changes in my blood levels, all to get to a point where I am now. Luckily, I'm finally on a drug that my doctor wanted me to be on. A year later, after all of the red tape and the hoops that we jumped through, I got here. But I think what was most striking to me in that experience was that I have a doctor who I love. She is great. And she was advocating for me from day one, going through all the processes and trying to get the paperwork submitted for me. She's advocating for me. And I was advocating for me. I'm well educated, I'm outspoken, and you would think those things would matter. But what struck me the most was that it felt like it didn't matter. So for a situation in which I was already dealing with a significant impact on not only my physical well-being, but my mental well-being, I was experiencing anxiety and that feeling of loss of control. The only thing this did was increase that loss of control feeling and anxiety. So I feel like for me, that's the part I took away the most. And maybe it is because I'm biased and I'm a psychologist by training. So that's the piece I often fall back to, is the mental impact or influence. But I would like that to be a real take-home point here, is what we can do to continue to support patients and caregivers in that space.
Thank you for that. I think that's really a very powerful message, because, you know, at Cancer Support Community, we provide psychosocial and emotional support, and that mental health component is very important. And we know, you know, research has shown us that there is a link, an increased incidence or prevalence of mental health concerns, particularly for people with, you know, a cancer diagnosis or those impacted by cancer. So not to minimize how important that connection is in this space, and how the use of step therapy can really exacerbate that. So thank you, Dr. Fortune, for sharing the results, and also for being vulnerable and sharing your lived experience with us as well.
Thank you.
Yeah, absolutely. So lastly, today, we will hear from Mr. Charles Husser, who is Federal Affairs Manager for the Arthritis Foundation, who is also a member of the Safe Step Ad Hoc Coalition. I'll just say Charles is very instrumental in leading the work that we do through that Safe Step Ad Hoc Coalition, and I'm really excited to have him with us today. So Charles focuses on congressional and regulatory affairs, lobbying, and coalition management. And today he's going to provide insights into the current step therapy policy landscape and possible solutions for improving access to care for patients, such as through the passage of the Safe Step Act. So with that, Charles, I'm happy to turn it over to you.
Awesome. Thank you so much. And I just want to thank the cancer support community for holding such an important event today. Before we dive into the legislation, especially at the federal level, I do want to underscore a point that you made at the beginning, Deneen, between insurance mandated step therapy and clinician mandated step therapy. They are very different, which is why many of the pieces of legislation that we see both at the state level and at the federal level don't explicitly ban step therapy. What we're looking to do through our model legislation is to make it easier for patients to request that exceptions process, and also make it more timely for patients to hear back on that exceptions process. And so before, again, jumping into the federal side, I just want to speak real quick at the state landscape. I wanted to give a quick shout out to many of my colleagues within the patient advocacy community who have worked tirelessly to get these bills passed at the state level. There's now almost 40 states that have passed some form of step therapy legislation. Many of the bills will differ slightly due to political climate and the needs of the state, but most of them do move forward those core principles that we look to have in many of these pieces of legislation. And it is very important to have this momentum at the state level, because that momentum will carry on to the federal level. It's a lot easier to walk into a representative's office who has had this step therapy legislation passed in their state and say that it's needed at the federal level. So thank you, everyone that has done such great work at the state level, and I encourage you to keep up the great work. So moving to the federal landscape, the Safe Step Act, HR 2630 S652, is the federal step therapy bill. It reforms employer-sponsored health plans, the group plans that we've talked about throughout the presentation so far, because many ERISA plans do not have these exceptions in place. They are exempt from state laws, and many other forms of healthcare throughout the federal government, such as Medicare, already have many of these provisions in place. So the Safe Step Act focuses primarily on those employer-sponsored health plans. In short, the bill would do three things. It would require a clear exceptions process that insurers would have to set up to make it a lot easier for patients and providers to request these exceptions. It would put timelines in place of 72 hours for non-emergencies and 24 hours for emergencies. These are super important because without these, a lot of the teeth of the legislation would go out the window, because we have heard from many patients that have said they have waited weeks, sometimes even months, to get these exceptions responded to from these insurers. And so because of that, these timelines would require that timely response rate. And then finally, it would set forth 5 cases in which an exception should be granted. So first, if the treatment that they're requiring the patient to step through has been ineffective previously. So they've tried it either on their current plan or a previous plan. If it's already been proven ineffective, an exception should be granted. If the treatment is expected to be ineffective and delaying effective treatment would lead to irreversible consequences, the treatment will likely cause or is likely to cause an adverse reaction to the individual. The treatment is expected to prevent the individual from performing daily activities or occupational responsibilities. I want to highlight this one real quick because it is different than many of the state laws that we've seen, primarily because it is within those ERISA plans, employer plans. And so with that, if it is expected, let's say a patient is a forklift operator and the treatment that an insurer would like that patient to go through will cause drowsiness. That is something that would allow them to not perform those activities. And so because of that, that is an exception within this bill. And then finally, the individual is stable based on the prescription drug that is already being utilized by the patient. And so for that, we've seen many cases where a patient is stable on a treatment and then they get switched off of that treatment only to end up back on that treatment and have that treatment not work for them. And so this will not only keep patients effective on the treatments that they're on, but also stop those delays that we see that can be very harmful for patients, especially patients with arthritis, because that very much so is a progressive condition. And because of that, even if they do end up back on a treatment that will help them, that delay that they have of weeks or even months before they get back to that treatment can be very, very harmful. So where are we at with the bill? In May 2023, the Safe Step Act was included in the Senate Help Committee's PBM reform package S1339. That is great and that is wonderful. On the House side, we have over 230 co-sponsors and are working with the Education and Workforce Committee to have a markup and include the legislation in their year-end PBM package. So we're at 2 different positions on both chambers. The Senate, we're in a very strong position because it looks like 1339 or some form of that will be what the Senate wants to move forward with in end of year PBM negotiations. So being included in that is amazing. On the House side, because of where the bill is as far as committee assignment, it's within Education and Workforce. And because of that, that committee does not do a whole lot on the healthcare side of things. And so we've been working with that committee as well as CBO sponsor offices to try to get a package together that the House can be okay with to move forward with at the end of year for PBM negotiations. PBM reform, I mentioned it, 3 or 4 times in the span of 30 seconds there. That is really what we're looking at towards the end of year. So Congress has adjourned for the year. They will most likely return for a lame duck session after elections have occurred. So most likely in that mid-November timeframe is when we expect them to return. And they have some things they absolutely have to take care of. So the number one is fund the government. They have a CR in place right now that runs until the end of December, and there needs to be either a CR put in place or a full year budget put in place by that December 20th timeframe, or there will be a shutdown. Otherwise, it is kind of up in the air what Congress will do in addition to that funding. So typically we'll see an end of year package at the end of a Congress that will either be rolled into that appropriations bill or be a standalone package. And that's really what we're focusing on leading into the end of the year. PBM reform has been the flavor of the month for Congress over the last 2 years, starting with the FTC investigation that was released in 2022, leading all the way into Congress saying that something needs to be done. The question is, what is it that they will do? On the Senate side, like I said, they have the Safe Step Act rolled into their PBM reform package, as well as some other proposals such as delinking, which would separate the fee that is charged by PBMs from the price of that prescription and require them to just charge a flat fee. On the other side, we also have spread price banning, with spread pricing, essentially this occurs when a PBM will charge more than they pay the pharmacy. So again, that's another form of profit boosting for the PBMs. So both of these are on the Senate side. On the House side, it more focuses on transparency, and that's one of the primary issues that we're running into in getting Safe Step included in the Lower Cost, More Transparency Act, because the House is focusing more on the transparency side than they are on the delinking, the spread pricing, and provisions such as that. And so as we lead into that lame duck session, it is very important for us as a patient advocacy community to continue to push the Safe Step Act and continue to push Congress to make these real changes in PBM reform that will help patients. As of right now, many of the provisions that have been offered up, both on the Senate and on the House side, are at the top level. They're not directly impacting patients. And we as a coalition believe that the Safe Step Act would be that patient-focused provision that could be included in PBM reform. So there's a lot of unknowns right now, especially as we lead into the end of the year. The election will have a large impact on what Congress decides to do, not just the presidential election, but also congressional elections. Congress is so close right now. House, such a slim majority, a slimmer majority than we've seen in years. The Senate, similarly, 51-49 right now. A couple of seats one way or another could decide where Congress sits. And because of that, what they do at the end of the year will drastically change. If there's a majority in both the House and Senate and control of the presidency, Congress could decide that they want to kick the can down the road until the next Congress so that they have a larger majority and can do more of what they're looking to do in the 119th Congress. So from this standpoint right now, until we get into lame duck, I will just continue to encourage everyone, reach out to your representative, reach out to Deneen, who can connect you with me if you are not already included in the Safe Step Act ad hoc coalition. We're always looking for more patient and provider groups that are looking to advocate for the Safe Step Act, and just continue to have this front and center as we move forward. And I'm happy to, again, connect offline and provide further information. Thanks so much, Deneen.
Yeah, thank you, Charles. That was a great overview of a lot of the important work that's taken place related to passage of the Safe Step Act. I wanted to ask if you could just talk a little bit about some of the recent activities the Safe Step Ad Hoc Coalition has done or is planning to do to continue that drumbeat. Because we know there is bipartisan support for this, right? And so what are some of the things we're doing, to keep that momentum going?
Yeah, absolutely. Great question, Deneen. So going all the way back to August recess, we took a smaller group of members within the coalition that are interested in getting more involved in that on-the-ground lobbying and really push Safe Step during August recess. We ended up with upwards of 10 new co-sponsors during it, but also it's important to stay front and center in Congress. A lot of times we see 15, 16, 20 different priorities swirling around during the week, and it's very easy to get some of these priorities lower on the list. And so because of that, it's important to keep the issue raised at all times, whether that's through a quick email to your local representative, an email to a committee chair's office, a letter, etc. That's really important, and that's what we focused on in August. Then once they came back in September, we held a briefing on the Hill, on the House side, for any staffers that would be interested in listening and learning more about the Safe Step Act. That's important because we're trying to drive co-sponsorship up. Like I said, we already have over 230 co-sponsors, but we want more because of the fact that once you hit that 218, that's a magic number because that's half the House, meaning it would pass if it reached the House floor. But many a times it's important to have more than that 218 because the more co-sponsors you can have, the more that it shows the committee and the committee chair that this is a priority for their members. And so because of that, driving that co-sponsorship number as quickly as possible is very good, especially when we're running on this timeline of end of year negotiations and PBM reform. And then finally, actually just this morning, we sent in a letter to congressional leadership. So Johnson and Jeffries on the House side, Schumer, McConnell on the Senate side, again, elevating this to their level to show them we have over 250 patient and provider organizations that are in favor of this, that want this to pass. And that's really something that does move the needle on the Hill. These representatives want to hear from their constituencies, and all of us organizations represent their constituencies. So having over 250 members sign on to that letter to be sent in was super important. And we'll continue to push the letter, as well as many of these other great events that are being held by our partner organizations.
Wonderful. Thank you. 250. That's impressive. And it might be helpful if after the webinar, when we send around the link to the recording, if we could also share, if it's available, the letter.
Oh, absolutely. Yep.
That, I think that would be also a great resource for registrants to have as well.
Absolutely.
Thank you. Thank you so much. So now we'd like to open it up and turn it over to you all. And the time we have remaining, we're going to open up for you all to ask some questions. If you have a question for one or all the speakers, you can submit them in the chat box now, or you can ask your question. So we're going to see if we have any questions coming in. So while we give you all time to think about some questions, I wanted to kind of open it up to Charles. You know, Dr. Fortune, she talked about, you know, our step therapy results, and in your experience, how can that type of data usually help in your conversations with lawmakers and their staffers, right? When we talk about the need for PBM reform, for example.
Absolutely. And just to start it off, I think it's super helpful. It's very much so a two-pronged approach when we go into many of these Hill offices. Number one is making sure that we have the data, because when a staffer is writing a position memo for their member of Congress on whether to support or not support a piece of legislation, that data is super helpful. They can refer back to it, they can include it, and that's really helpful when deciding, hopefully, that they're going to support the Safe Step Act. Now, that is always super helpful in conjunction with the patient story. The patient story is super helpful. It really brings kind of a humane side to it. Again, you know, just asking a patient what their story is and allowing them to sit there for 10 to 15 minutes and speak to the staffer and explain what they've gone through and answer any questions that they may have. Having both of them going into the meeting is super helpful. I was a former Hill staffer myself, and it was always that tandem that resonated with me. You hit the emotional side with the patient story. It's something that can resonate with them as they walk out of the meeting and say, this is something that I want to do to help this patient. And then having that data to back it up, especially when you get into some of these offices that are hawkish about the deficit and hawkish about the financial side of it, how much it's going to cost. A lot of times that data will be what rationalizes that money that they are expecting to spend. So super helpful to have both of those, and always welcome new information and new data that comes down the pike.
Wonderful. And one last question for you. You know, you mentioned that, you know, Congress is back home in district. Would this be a time, say we have some patient advocacy groups on the call that have like, they have a federal presence, they also have a local presence. Would this be the time for them to maybe reach out to their congressperson or senator and maybe try to have an in-district meeting or an opportunity to connect with them back home? What do you think about that?
100%. So what I'll say is anytime is a good time to reach out to the district staff, because of the fact that they are obviously very interconnected with the Washington staff. So even if someone that you speak to at the district level may not be a policy person or may not be the health staffer that handles it in Washington, that will always get relayed back to Washington. And so anytime is good, but this time specifically, there are two times every 2 years that I would say are the perfect times to meet in district. One is August recess that happens every year. They take the entire month of August off and they're at home doing events, doing campaign stops, etc. Great time to meet with them. And then during election years, this October timeframe, most of the time Congress will take the entire month of October off to allow their members that are up for re-election to go back to their districts and do a lot of their campaign stops. And this is the perfect time, candidly, especially something like healthcare is something that all of these representatives and senators are going to want to hear during election season, because frankly, they're always trying to figure out what that issue is going to be that can move the needle for them within the election. And something like this, which is very patient focused, is always great to put in front of a representative or a senator before they hit election season. So yes, absolutely. And if there are any questions about how to specifically do that, I'm happy to answer those as well.
Wonderful. So Dr. Geynisman, I'd like to turn it over to you. I think we saw one question come in, but while we're getting that question teed up, I wanted to ask you, you made one point during your discussion where you said patient advocacy, we have a role to really help. In your experience, the patient advocacy groups that are on the call, what is one thing that we could do in your experience? I'm sure there's several that could really help empower patients and their caregivers throughout this journey. What would be one piece of advice, I'd say, that you would give to us on the call?
Make it easy to be available to the patients and their families for them to sort of know about you and know how to reach out to you to get sort of the support that you have already available and worked so hard to have. Because I think my experience, a lot of patients simply just don't know that these support organizations exist, how to reach them, what resources are there. There's just such a huge amount of information that comes their way when they're diagnosed, that it's really hard to kind of sort through it. And so I think if there are ways to be available, easily accessible, that's really, I think, a key step. Because I think once patients find those tools and those resources, there's a lot that they can get out of it. But I think a lot of them are just not getting them at all.
Great. And so, Erica, I'd like to turn it over to you to kind of give you one last thought or word to kind of like wrap it up from the research perspective, right? Because what I want our participants to understand is, like, we kind of want to take you through the trajectory. It was very intentional that we started with Dr. Geynisman to kind of share like what's happening in practice, what's happening in the real world, what are patients experiencing that we know. And then we wanted Dr. Fortune, Erica, to kind of share, what is some of the latest analyses we did and what did we see, and round it off with Charles kind of sharing there is a role that we have here as a patient advocacy community to really champion on behalf of our patient community to get some real reform passed. And so, Erica, with that, what is one overarching thought you have to kind of tie all of this together that you would like to leave with the patient advocacy community that's on the call today?
I appreciate being given the last word here. This feels special. And I'll say what I would say is a real take-home message from this is that what we're seeing in the current work that was done at CSC is that there's not enough evidence to suggest that step therapy in its current form and function is in fact doing enough or saving enough to make it justifiable, given what the actual cost is to patients, to caregivers, and honestly to everyone else serving in the healthcare organization. When we look at some of those other facts I shared earlier about actual increase in healthcare utilization, depending on the types of drugs or number of drugs people are put on before they may be put on the right drug for them. So my take-home message would be, that I don't think currently there's enough evidence to suggest that it's warranted. And then my personal note message would be that continue to offer that support and care to any patient proactively. I think at this point we have to anticipate that step therapy and fail first is likely impacting patients in lots of different clinical settings. And so doing whatever we can to ask them about that directly, right? Are you feeling impacted by this? How can we support you? What additional resources can we provide? I would offer that from a patient lived experience space as well.
Wonderful. Thank you. Thank you all. So on behalf of the cancer support community, I want to once again thank our panelists for sharing their insights on this issue and for all of you who attended today's event. Looking forward, we are excited to continue our discussion around at our upcoming Utilization Management Summit that will take place in person on Tuesday, November 19th at the National Press Club. So please mark your calendars, Tuesday, November 19th from 12 p.m. to 4 p.m. at the National Press Club in Washington, D.C. Please look out for an invitation to the event later this week. We really hope to see you there. We're going to have more conversations that are broader than what we talked about today. There are other hot topics that are happening in that we're really excited to talk about, just to kind of tease a little bit. There'll be some discussion on artificial intelligence, of course, in value assessments and incorporating the patient voice. And you might have a post-election outlook as well as it relates to healthcare. So with that, we really hope that you all found today's program valuable, and we encourage you to get involved with CSC on this issue as it continues to evolve. That concludes our program today, and thank you so much.